Today's Service Providers Conference is the first in the next series of Service Providers Conferences. This is webinar 1. It's on Telehelp, and I'd certainly like to welcome all the participants today. I'd like to begin by acknowledging the traditional owners of the country that we're on, and pay my respects to elders past, present and emerging, and also acknowledge the different lands of people wherever you may be, and your relationship to the land that you're on. I'd like to introduce today's moderator, who's Naomi Crafty, well known to most of us in Victoria and elsewhere. Dr. Crafty is the course coordinator for Turning Point, Monash University's new online course, the Graduate Certificate of Telehealth, something she's been working on of recent times. Naomi's been in her existing role at Turning Point in the workforce development management role for about 8 years. And she's been teaching for 20 years in counselling and psychology at Swinburne University, which is a very long time indeed, I think, for anyone working in the human services. She apparently is really excited at working in innovative treatment approaches such as telehealth, and I think there'll be a lot to be learnt in that space, and I reckon as she suggests, it'll be something that's really emerging now and into the near future. Apparently, Naomi also apologised for the condition of her hair during the webinar, which is a reminder of some things which just can't be made right virtually. But I'll just hand it over to you this time, Naomi, before I get myself in any more trouble.
Yes, thanks, Sam, and sorry for being so superficial and getting you to make that apology on my behalf. But I was looking for a bit of sympathy from Robert and Steve in the COVID-free states out west. Just to feel sorry for ourselves that I guess if the worst thing is that we can't get our hair done, things aren't all that bad. But
if I can just cut in, I'm not going to be have any sympathy for anybody who's complaining about not getting to the hairdresser. That's not something I've been able to do for a very long time.
That's all right. Well, we'll all have some empathy. We'll all show some empathy for one another during this webinar. So thank you, Vada, for inviting me to moderate this webinar. As Sam said, I'm very excited. I could talk forever on this topic, but it's actually not my job today to talk. It's my job to listen to some very experienced people who are going to be giving us some information about working from a telehealth perspective. But I'd like, before we start, I'm going to invite you to participate in a couple of poll questions just so that we can start thinking about this topic. So the first poll question is, where do you normally go for advice on telehealth counselling? So if you could answer one of just question 1, where do you normally go for advice on telehealth counselling? And then while we've got it up, we'll do question 2 as well. But question 2 is, when did the first recognised telehealth consultation take place? So was that 500 BC, 1879, 1979, one of my favourite years, or March 2020? So 2 questions there for you to answer. I'll just give you a moment to do that.
If I'm not mistaken, some of the questions are locked. Is that what people are experiencing?
So how's it going, Julia? Have we got some results?
Sorry, I was trying to click on mute. Yeah, we have some results coming up. I've got 42 out of 49 people have replied.
Okay.
Might be just me that's locked.
It might be. I think the
You're a
panelists,
presenter.
the panelists can't vote, Sam.
Oh, jolly good.
So, do we have some results now, Julia?
Yes.
Put those up.
Share results. Can we see those results?
Okay, so the first question, where do you go for advice on telehealth counselling? Well, the good news is there's no wrong answer for this particular question, but it's interesting to me that, and I might get our panellists to comment perhaps when we start our general discussion. And interesting to me that the majority of people, or the answer that gets the largest response, is advice from peers. So I think that's not a bad answer as long as your peers know what they're doing. So the correct answer is that you go anywhere where people have good knowledge, good evidence-based knowledge, and know what they're talking about. So if you're tuned into this webinar, you're definitely in the right place, because our panelists today definitely know what they're talking about. So there are lots of different sources of knowledge, but they need to be recognised sources. And the answer to question 2, when did the first recognised telehealth consultation take place? And nearly 70% of people have said 1979. Well, guess what? Surprise! The correct answer is 1879. And that surprised me too when I was doing a bit of research in this area. So in 1879, by the way, was just 3 years after Alexander Graham Bell patented the telephone. So just 3 years after the telephone was patented, according to the Lancet, which is a good source of information, a doctor in London was called in the middle of the night to respond to a family who had a sick child, and gave the first telehealth consultation over the phone in 1879. So telehealth has certainly been around a long time, well before March 2020, which is when I guess we started talking about it quite incessantly. Lifeline, for those of you who are interested, Lifeline started in Victoria in 1963. So even here in Victoria, we have been running telehealth services for a considerable amount of time, nearly 60 years. And Turning Point has been delivering telephone and online services for the AOD sector here in Victoria for over 30 years. So telehealth is not a new phenomenon. So let's start from that perspective. Now, I'd like to introduce our panellists to you. The first person I'd like to introduce is who is in South Australia as we speak, I think, is Associate Professor Robert Alley. Robert is a public health physician and a specialist in addiction medicine. Until October 2016, he was the Clinical Director of Drug and Alcohol Services South Australia, a role he held for over 30 years. Currently, he is a Senior Research Fellow at the University of Adelaide. Robert is a member of the Australian National Advisory Council on Alcohol and Drugs, a member of the Cochrane Alcohol and Drug Group Editorial Board, and the WHO Expert Advisory Panel on Drug Dependence and Alcohol Problems. So welcome, Robert.
Thank you. Lovely to be here with you.
Good, thank you. And even further west than Robert, over in COVID-free WA, is Steve Allsop, Professor Steve Allsop. Steve has been involved in prevention, treatment and policy research and practice and service management for almost 40 years, working in government and academic positions. He's been the director of 2 Australian National Drug Research Centres in Adelaide and Sito, and subsequently in Perth, injury. And for many years, he worked in senior roles with the WA Government Drug and Alcohol Office. Steve is currently involved in a great big long list of activities, so I won't name all of them, but he is currently the chair of the WA Network of Alcohol and Other Drug Agencies, amongst other things. And then our third panellist is James Sito. Unlike Robert and Steve and I, who have all put in our CVs that we've worked for decades in various roles, James doesn't mention exactly how long he's worked because he's obviously noticeably much younger than us. And it's great to have a fresh young perspective on all of these things. So it's lovely to have James with us. James is a psychologist with experience working with anxiety, depression, sleep disorders, relationships, trauma, and related substance use problems. James has been with Reconnexions since 2011, where he began as a volunteer on the telephone support line. More recently, in the last few years, he's been working as a benzodiazepine withdrawal counsellor, offering support to people withdrawing from benzodiazepines and assisting clients with associated anxiety and sleep disorders. So James, like perhaps many of the people watching this webinar, was suddenly found himself forced to work from a telehealth perspective, or shifting from a face-to-face to a telehealth perspective earlier this year. And he's going to talk to us a little bit later on about his experience of pivoting to working in telehealth. For those of you who are watching this webinar, if you have questions for any of our presenters as we go along, please pop them into the Q&A box, not the chat box, so I'll be looking in the Q&A box for questions for our presenters. If suitable, I might ask some of those questions as we go along. Otherwise, there will be time at the end of this webinar for me to ask questions. So we're going to begin. And I'm going to begin by talking about this particular guide, which is available on the internet. And it's a fabulous document that I'm really fortunate that we have in our sector. And we're going to talk quite a lot about what is in there and and how it can help us in our work, working with people with substance abuse problems. And it's a book called Telephone and Video Consultations. It's a University of Adelaide publication. And both Steve and Robert have been involved in putting this particular document together. I know why I think it's so fabulous, but I'm going to ask you, Steve and Robert, to tell me why you think we needed another telehealth guide. So there are quite a few out there, but this one I think adds something to the conversation that a lot of the other telehealth guides don't have. And I wonder why you decided to put this together and what your rationale was for this guide. I don't know who'd like to start, Robert?
Yeah, look, I'll perhaps kick off on this one. I guess that you're right. There was a lot of guides around, but actually there's a paucity of information that's specifically targeted to the alcohol or the drug sector. And we thought it was really important to be able to harness what we know about how to provide effective care in an online environment. The guide tries to remind us the things that we already know about effective counselling, because there's lots of skills and expertise we bring to that, but it builds on that where generic approach, and then particularly highlights things that are different, the key differences that would separate the way you talk with somebody in a face-to-face setting versus an online setting. And it amplifies those points by providing practical examples, gives guidance about ways you might say or do things. I guess the other key thing that we thought was important is that a lot of guides are generic, and so they provide very useful general information, but they don't deal with those difficult situations that we all know that we encounter in face-to-face settings as well as online. So we drill into those challenging behaviours as well, which we think is a real boost and an add-on.
Thanks, Robert. Steve, did you want to add anything there?
If my mouse will allow me to unmute, yeah. I first got involved in formal telehealth approaches. And I say formal because when any of us answer a call to a client, we're actually engaging in and should be using the principles and processes that go for good telehealth. I first formally got involved in it in I think it's 1982, 83, which shows how old I am, working in a psychiatric hospital with a colleague who wanted me to try an online in those days was a wire through a wall assessment using an old Apple computer. And I worked in an alcohol and drug treatment unit in the psychiatric hospital. The psychologist worked in Stirling University, and he wanted to try an online assessment. And so we had all these big burly shipbuilders from Western Scotland who went on, first time they'd ever seen a computer, many of them. What surprised me was a large proportion of them actually preferred doing the remote assessment compared to doing the face-to-face assessment, which surprised me. And part of that was they essentially felt they didn't feel the pressure of face-to-face, so it gave them time to think, was what a lot of them said. So that got my interest in it. And then working in Western Australia more recently, which I've been doing for the last 33 years. So, but working in Western Australia, we have enormous distances and very remote areas, as occurs in other areas of Australia. And I was really impressed by Women's Healthcare Services in Western Australia, who set up a telehealth support service linked to remote services. And again, what they found was that a lot of clients preferred it because in remote areas, your anonymity is hard to protect when you're going to a specialist drug service or a specialist other service. So it was preferred by a lot of people because it was a way in which they could access the service readily, and it was a way in which they could do so without them bumping into the local clinician every time they went out of the door. So got interested in it, and then I guess with COVID forcing us into looking at this issue more intently, Robert and I had been involved in some training for telephone services in the Philippines. I and Robert had been involved in telehealth services through the Alcohol and Drug Information Services in South Australia when I worked there, and I was responsible for the services here in Western Australia. So it was a case of this was happening, there was a sharp focus, and like Robert, I felt that there wasn't something that had brought together the particular challenges and issues and approach that we had with the existing telehealth guides. So Robert proposed that maybe it was a good idea to bring together our expertise with John Marston in London, and here we are.
Yeah, so that was exactly what I was thinking. You obviously achieved your aims because as I was reading the guide, I think it's a fabulous opportunity to combine in the one document the sort of counselling skills that are required for working from a telehealth perspective with things that are specific to people working in AOD, as well as looking specifically at working from a telehealth perspective. So it's sort of all there in one guide, whereas often we see just talking about telehealth, just talking about AOD, or just talking about counselling. So congratulations, and I think it's a really handy document for everyone to look at. So obviously you've both got a lot of experience working in this area, and we know that I think we ignore sometimes that there's a lot of similarity working face to face and working online or over the telephone or video conferencing. So we shouldn't sort of throw out all our existing skills and abilities just because we're working in a different medium. But what are some of the key differences working with people virtually or from a telehealth perspective?
Maybe I'll start on this one and then Robert come in. It's the obvious things. We rely, whether we know it or not, whether we formally make it a part of our work, we rely so much on visual cues. When Robert froze a minute ago, we could hear his voice, but we couldn't see it. And so that does make a huge difference. And one of the things one of my colleagues, Sue Healthcott, did early in her training for people working on a telephone counselling service was get people to sit back to back to practice their counselling skills. And what a difference that made to people immediately. It's an incredibly concrete way of showing that if you can't see people, you're not picking up on the non-verbal cues or the familiar non-verbal cues. There are other non-verbal cues, but we rely so much on our vision. So that's the obvious one. And then there's the practicalities. Does the technology work? How confidential might it be? Is the person comfortable with it? So I've given an illustration from the 1980s when a bunch of Glaswegians were comfortable with it, but a lot of people are uncomfortable with it. They're a bit suspicious of it. So it's the sort of physical practicalities, but it's also the ability to physically reach out and touch and see the person in front of you. They're the challenge. Other than that, as you just said, Naomi, you're actually relying on the same principal skills that make you a good listener. But I think it's a little bit more challenging to build up, if you like, the therapeutic alliance. Hand over to Robert.
Yeah.
So I think Steve makes some really important points. And just to add to that issue about the differences, one of the things that I think is really different is preparation, particularly when you're organising sessions with people that may not be tech savvy. You might need to think about, do I need to do a trial run? I find it useful to send them written details about how to download the app, how to log on, what devices work. It's these little things that get in the road of how to communicate. Certainly in the client base that I was looking after, data was always an issue about whether or not they actually, because a lot of people are using smartphones these days, and then do they have enough data on their phone to be able to get involved in either a phone consult? Can they pay for it? So that has been an issue. I'm a visual counsellor. I like to engage with people on doing things together. So I like to be able to share screens, and I like to be able to show things and share information. And I found even with university colleagues, not everyone knows how to go about doing that. So walking people through that and feeling comfortable that they can do it is important. But I guess, as Steve said in the beginning, a lot of the basic skills, they're the same. But when you're trying to ensure privacy, because you're not in the same room, it then links into one of the other key areas that I think is different, which is risk management, because they're not there with you. And if they are troubled, if they're despondent, if there are problems, do you know how to get in contact with them? Do you know where they live? Do you know who their other service providers are? That kind of thing that ordinarily in the room you would deal with face to face. When you're on the phone or a video consultation, it's good to have been pre-planned to think about those things before you get started.
So having a backup plan is essential. As we all know, technology goes wrong, suddenly it drops out. Suddenly they've realized that they don't have enough data. One of the services that I worked with, they had a lot of clients, particularly in country areas, in remote areas where there wasn't always a good signal. That's improving, but it's still a way to go in some places. So they actually did their telehealth in a a general health setting. So the person was in a particular place where there was good technology, where there was good bandwidth, and where there was support mechanisms around that person if it was needed. So that doesn't mean you have to do that all the time, but it is about thinking about those practicalities. As Robert said, do they have enough data? Is their battery going to run out? Is your battery going to run out? You know, what's your bandwidth like? So trialing it and then thinking about ways in which you can meet the technical challenges as best you can.
Thank you. Yes, so, Steve, your story about sitting back to back for training in telehealth reminded me when I used to teach in this area, and we used to sit back to back and we used to do this with our hands. I'm not sure that anyone has a phone that looks like this anymore.
Now it's this.
Oh, okay, that's right. So we've talked a little bit about some of the essential things that we need to think about when working virtually with a client. What about the things that we should avoid? What are sort of the biggest difficulties working virtually?
Well, I might start on this one. I think we've all had a situation where we've been on Zoom with colleagues and suddenly you're aware they're trying to multitask. And nothing is more annoying than feeling divided attention. So one of the key things that I think is critically important is to concentrate on the job at hand and make sure that you are really connected to them. And I think it is also one of the challenges that we find in video conferencing, and I know I'm guilty of this, is reducing posture, because you stop mirroring the person that's around you and you tend to become closed down. You're sitting there and you may hunch forward, and it gives the appearance of hostility or anger or disinterest. So I think that's critically important. In a normal consultation, I would not ordinarily take notes contemporaneously. I tend to, when we finish the session, I'll write up the session and do it then. But online, I see a lot of people do focus on trying to take notes. And if you're going to do that, it's critically important you tell the person that's what you're doing, because as soon as you look down, you see top of head. And for Steve, that could be blinding because of the reflection. But for me, what it does is it kind of confuses me about well, what are you doing? What are you interested in? Because they can't see what's happening. So let them know that that's what you're going to do and to move in. I guess the other thing that is also tempting is that clinically we use silence often in counselling sessions to evoke opportunities for personal reflection, to think about the meaning of what's happened, and it can be an aha moment for them. But online, it somehow becomes a bit less confident to do that. And often what we do is that we engage in, so we start to dominate the conversation. And I think that's one of the things you really need to avoid doing. You've got to give them the opportunity to talk. People can be timid initially when they're first doing it, so we need to give them an opportunity to get out of their shell and take ownership. So, Steve, what are your thoughts on that?
Yeah, I mean, exactly the same. I mean, it's not surprising. Robert and I have worked together for 30 years. Just a couple of things. I think, it is easy to, as Robert says, to look distracted, even if you're not. When a person's physically in front of you, then you're looking at them. I don't actually know where I'm looking because I've got people all across the screen. So that you really do have to make sure that you're talking to the person, and you're not talking like this and look, as Robert says, or pick up your phone because a message has come through. And you would never do that when a person's in a room, but I see it all the time when people are in teleconferences and so on. even as they're speaking, or they start speaking to someone else who's brought in a cup of tea for them or come in and asked a question. So it is about setting up your space in your room so that not only are you not interrupted or distracted, but it doesn't look like you're distracted, that you turn off your email function so it's not going ding, and you're also not looking at the message that's popped up in the bottom right-hand corner, or turn off your phone if you're on a telephone and you don't have video. I think it is the silence issue is really important. I think when somebody's sat in front of us, we can see that they're thinking. So you pose them a question. I think on the telephone, you sort of silence, or on video, silence is lost communication. So, but I think you also need to communicate to the client that that's what you're going to do. That look, I would say from time to time, I'm going to give you time to think. I'm still here, because that's the other thing. Hello, you still there? So you need to let the person know that you're going to give them time so that it's expected. And if there is a silence, sometimes rather than then filling it, is to say, look, I'm just giving you a bit more time to think, but I'm still here listening, and so that the person doesn't think that there's no one there or you've suddenly lost interest in them. So, and Robert says a really good question to keep asking yourself is, who's doing most of the talking? And if it's you, then that's maybe an indication that you need to change what you're doing. And whilst sometimes interruptions can be useful, particularly in the early stages of an engagement, it's really important to get that right. And I think the other thing is to ensure that you are communicating that you're listening. So if you're online, you can do that by nodding. But obviously, if you're on the phone, then it's using non-verbals or verbals by saying, I see that, thanks for that, or so you do have to be much more mindful that a nod and a smile might not be enough. And that, again, as going back to the first point, set your system up so that you're not going to be distracted, you're not going to be interrupted, you're not going to be staring into the corner because your child's waving at you. So all of those things are, just emphasizing the points that Robert's made.
Actually, I'll add my 2 top tips for focusing your attention. You prompted me to remember these. Where to look. I've got a little dot with a smiley face on it next to the green dot of my camera to keep reminding me that's where I should be looking, because it is tempting, as I am doing now, looking at Steve's image when on screen it looks funny. The other thing that is really helpful is that if you're taking notes on your keyboard, so you're typing into your computer, if you use a headset for your sound, you will find that actually stops the noise of the keyboard. Because if you're doing it through your computer device, it transmits the sound and it is really jarring. So that'd be my top 2 tips. Yeah.
Thanks, Robert. And James is smiling and laughing there because people James's age know that, or just automatically they're born with that knowledge. But the rest of us had to learn it the hard way, I think.
Glad to know I'm not stuffing that up.
We're not excluding James from the conversation, by the way. So we're just starting off by talking a bit about the contents of the guide that Steve and Robert wrote. And then we'll be bringing James into the conversation a bit later to talk about his experience of actually working from this perspective.
I was just wondering if James was smiling because he was touch typing with his mute on while we were talking.
Ah, that's right. Could be. It could be that James is doing 1,000 things at once, but we don't know it because he's so adept at doing it.
Absolutely not.
Okay, so I think we've all had experience now of seeing partners, children, animals, workmates, all sorts of things happening in the background of Zoom meetings. So we know that when people are working are speaking to us virtually, that they may not, unlike a face-to-face consulting room, they may not be alone. So how do you think we should manage issues around confidentiality and safety in the online environment? Who'd like to start?
Oh, well, I mean, again, it's the principles are still the same as you would in any face-to-face encounter. But obviously some people may be a little bit anxious. So where are they going to be? Are they going to be out on the construction site? So some planning about where they might be. Is there a place that they can be? Is it possible for them to use headphones so that your voice isn't booming out to all and sundry? But I think talking beforehand about what options there might be so that you can anticipate any threats in terms of interruptions. And getting that right from the beginning rather than being surprised by it. Encouraging them if they can to use headphones so that then it's a little bit more private. There's not everyone else listening into what's being said. Finding a location that's private so there aren't going to be interruptions. From your point of view, the same principles apply. Be in a private space, ensure that the client knows where you are and knows, and if again, think about using headphones if your door or wall is thin. I've used a background at the moment so that interruptions behind me, like the state of my office right now, wouldn't distract someone. So using a background and maybe not where your favorite place for a holiday is, but something that maybe advertises your service, which is what I've done today, so that there's a neutral background. But ensuring again that in the same way, if you had a client coming to see you, you would have a sign on your door saying "Do not disturb." The same principles apply. You need to be in a private place. The client needs to know you're in a private place. There mustn't be interruptions. Work with them to find out where they can be so that it's private, and talk about technical options such as headphones that can help them maintain a sense that this is a conversation between you and them. Robert?
Yeah, look, all good points, Steve. I think with the best will in the world, sometimes things do happen if you're in your work environment where you do have intrusions. One of the things that I don't do is tough it out. I will stop the consultation, resolve the interruption, and then resume. I think there's a temptation that we know their colleagues, we know that it's confidential, we got headphones on, but it's very unsettling for a person who's talking to you. So I stop it cold. There have been occasions when I've been involved in supervision and training, and we would, if there was in a face-to-face, that we would record the interview, and we would do that for discussion and training afterwards. If that's going to occur, as today is being recorded, we would let people know that it was being recorded, the purpose for the recording, and what would happen to the recording. So it's important that before you start, you've got permission to proceed on that. Sometimes the interruptions are further afield than you would like. The leaf blower, the lawn mower, road traffic noise, all sorts of things that interrupt, and they are distracting. I think what tends to happen is that people then just elevate their voice to try and talk over it. But what I tend to do, as we've been doing today, is that if I'm not actively talking, I mute, so that if there is an unexpected noise in the background, it doesn't interfere with the line of concentration.
Thanks, Robert.
And if I can add one thing, sometimes people in our area of work, because of the stigma, because of the sometimes illegality of behavior, there is, and particularly with some substances, there is a little bit more anxiety and well, paranoia, and degrees leading up to that. So I think it is particularly important that some people are going to be a little bit more paranoid about remote access and, you know, things being online and recorded. So I think it is important that we do everything we possibly can to talk this through before we actually start, and talk about the usual issues to do with confidentiality, and reassure if there's suspicion or anxiety about the remote nature and the online nature of the call. Because if there is that suspicion, it's going to be hard to progress. And that might mean, again, that, well, making sure that what we're doing is talking to the person about what they are concerned about, not telling them what we think they should be concerned about. Now, that's a general principle in any encounter with a client, but I think it's particularly important to allow them to become comfortable. And so lots of people contact our services not because they want to give up drugs, but because they want to get on better with their partner, or they want to sleep better, or they want to get their boss off their case. And I think it's always important to start with what concerns the client has and not rush to tell them what we're concerned about. I think it's particularly important when we've got this medium or these media that might exacerbate that sense of discomfort or sometimes paranoia.
Thank you. Just to make sure that everyone's still with us, we've got another poll question for you. So you're all ready. This time we're going to ask, there's a recent study that was just published in the last couple of weeks, actually, about the transition to telehealth by Victorian healthcare workers, and what percentage of clinical staff indicated that they had no prior telehealth experience. The four options: 10%, 25%, 50%, or 90%. So if you'd like to indicate your best guess. So this was a study not specifically in the AOD sector, more broadly across Victorian healthcare workers. What percentage of clinical staff had no prior telehealth experience?
We've got about 40 people out of 60 answered, so I'll just leave it open for another moment.
And the results are... Okay, so about 50% of you guessed that 90% had no previous experience with telehealth. So the correct answer for this particular survey was 50%. 50% of people who were surveyed indicated that they had no prior telehealth experience. So it's still a considerable number of people, and an interesting question, which I think hopefully we'll get to with the panelists later on this morning or this afternoon, is what is the future of telehealth. And I think we might all assume that that number will go down from now on, that from now on having experience working from a telehealth perspective is going to become the norm, rather than something that's a bit more unusual. So just one more question for Robert and Steve, and then I'm going to bring James into the conversation. What is the best way to deal with expressions of intention of non-suicidal self-injury or suicide when working with somebody in a virtual environment? Robert?
Okay, well, I think that one of the most important things is to take disclosure like that seriously, and to respond to it in a way that shows that you are thoughtful and concerned about it. But what you're trying to do is to communicate with them in a way that helps to clarify what the problem is and open up options in your discussion with them. Because at the moment they've identified a solution which is not really helpful or in their interest. A lot of that is around assessing risk. So trying to understand their intention and whether that is going to move into an action or whether it's actually already commenced as an action. So do they have a plan? How detailed is it? Have they worked it out? Have they done it before? Listening is critically important. I think what we've done so far is talk about the importance of listening to verbal cues. So the style of communication, the content, their breathing patterns, the tone and intonation in their voice is all going to give you a sense of the urgency of it. I think you've also got to connect to their feelings, being clear on the problem. What was the problem that has led to this idea? And I think that's really quite important that you're very specific about that, because you can't be solutions focused unless you know the detail. So on the harms risk side, though, that would be the assessment I would take. But I think it's also important to balance that against protective factors that may be in place that may be able to help them. Are there people that they can call on for assistance? If they thought of doing this in the past, what turned it around? Can we draw on that experience? Start thinking about developing a safety plan, a connection for future commitment, because getting those commitments can move people forward. One of the really important things that I think that when these things do happen is the opportunity to also talk with colleagues afterwards. The importance of debriefing can't be overstated. This is not something you keep to yourself and go home. It's really important that you have an opportunity to talk it through, to think it through in a way of the things that you're able to do and to help the person come on top of, but also to feel supported and understood in your workplace, because it is a very stressful thing to go through. Steve, what are your thoughts?
Well, I won't repeat all those things that I agree with them. I think, firstly, it's important, and a lot of experienced counsellors, which I'm assuming meant most of the people are listening or watching would know this. But a lot of clinicians are reluctant to talk about suicide risk because they think that's going to increase the risk that it'll happen. There's no evidence that that's the case, but there is evidence that by raising it, you can actually do something to prevent it. So I think it's really important that it is raised, it is discussed in the way that Robert talked about, that it is discussed with practical steps that to prevent it. For example, trying to get some sense of how likely it might be, developing a contract with the person, finding out what support mechanisms they have. And this all, but then the practicalities take us back to the beginning, knowing the client's telephone number, having some information about where they are, whether that's their home address or in another setting. Because there might be the occasion where you actually need to direct emergency services, support services to them. So if you don't know their phone number and you're on the phone and they disconnect the call, it's going to be very hard to direct services there. So having some sense of where they are, is there someone that you can contact in the event of an emergency? If you think that there's a possibility that there is a suicide likely to occur or possibly occur, then making sure that there are support people, services around that person. If you think that there's a suicide that is underway, keeping them on the phone and getting the emergency services there as quickly as possible. And also engaging, where indicated, engaging with mental health services to support that person. And that means that this isn't just what you do. This means ensuring that your agency where you work, what is the policy about people saying that assessing that there might be a suicide risk or that there's a suicide in progress. And they need to be reviewed in the context of online connection. And a key element of that is going to be, do you have a backup contact plan and know where that person is if you need to direct emergency services there? And then to emphasize the point that Robert made, ensuring that you debrief, both in terms of yourself and your well-being, but also to make sure that you do this as quickly as possible with a supervisor or colleague, so that you can make sure that your determination of the risk is something that's shared by a colleague, so that you're not on your own, but also you've talked it through, and that may change your perception of what the risk may be. But critically, it's about the agency having policies, you being familiar with those policies and updating those policies so that they fit the online context.
Thank you. So James, all right, you're allowed to speak now. So James, this must be a scenario, I guess, at Reconnexion that you come across, unfortunately.
Yes.
Reasonably often. So how do you manage these situations?
So first of all, I guess I think what Steve and Robert are saying is perfect. And I just want to say as well that myself and everyone else at the team had a read of the guide before today, and we're really impressed at just the breadth and the depth of it. But in terms of managing suicidal risk over telehealth, I've seen it from a few different perspectives. So I did about 6 years on the telephone support line at Reconnexion, which is more around providing information, advice and support. And on that side, you know, we're not counselling. It's a much more mild intervention. You kind of sometimes get people calling in, feeling a bit depressed, sometimes expressing thoughts of suicide. And really in that context, it was around doing an assessment and referring on to appropriate services. We don't really have the capacity to do much beyond that. And if necessary, contact emergency services or the CAT team, trying to get at the start of the call, because it's often anonymous. If we're concerned, we might try to get a contact number fairly early on, particularly if we're capturing that they seem a bit hopeless or a bit flat, that sort of thing. Since we've shifted over to telehealth more recently, it's within the counselling program, and I should mention, we've actually been doing it we were doing phone, I think, for a while before COVID, because we're a very small service and we're technically a statewide service. So it's been a familiar thing for us. And we're all in the practice of making sure that even before the person comes into the service, we have an emergency contact. And in the first session, I would talk to them about, you know, who is this emergency contact? What's your relationship like with them? If I was to contact them and I had to discuss some of this stuff, how would you feel about that? Are they someone who's likely to be helpful or maybe not so much? And I tend to step people through exactly what will happen if I'm concerned about risk. So first of all, we'll try to develop a safety plan together, and that's including some 24-hour phone lines because I'm only available by appointment. And if we're not able to develop a good safety plan that can help them to stay safe, or if for some reason I'm really, really concerned, that's when I'll try and contact their emergency contact. If that isn't able to happen, then it might involve a welfare check. And if I've got them on the line and we've tried everything and nothing's working, then that's when I would be contacting the CAT team. So in the very first session, I would step them through that whole process, regardless of who the client is, just so that they have a really clear understanding of this is exactly what's going to happen. And at least in the work that I do, pretty much because of one of the main withdrawal symptoms of benzos is suicidal ideation. So a majority of my clients would have some sort of experience of that. And I think it has been elevated with COVID-19 and people feeling a lot more isolated and hopeless.
So James, I'm interested to know, because Reconnexion as a service, as you said, has had some experience with telehealth, but all of a sudden, on maybe the 13th of March or thereabouts, you would have realised that being able to see clients face to face was no longer possible, and you would have had to make that transition to working from a telehealth perspective. So how did you manage that as a service, and what did that look like?
Yeah, so around that time, we had done phone counselling, but very little video counselling. So we had to learn, I think, like most people, really, really quickly. And, the things that we were thinking about is our intake processes were really important to refine, because we had to start thinking about making sure that if we're working with someone via telehealth, do they actually have a doctor or someone who's accessible nearby, face to face, to deal with stuff that we simply can't manage over the phone or over video. We had to actually draft an entirely new counselling agreement that we go through with clients in session one, talking about the privacy, as Steve and Robert have, and talking about, I suppose, that setting some really clear boundaries around what counselling actually is over video, because I think over video and phone, some clients have sort of thought, oh, maybe it's just a bit of a check-in, or maybe it's just a place where I get information from you and I ask you questions. It's not seen as much as a reflective space as when someone actually comes into the office. So doing a lot more work on the front end in terms of setting expectations. And I think what they were saying as well about making sure that people are familiar with the telehealth stuff. We have the benefit of this fantastic, amazing group of volunteers who do our support line stuff. And before new clients are booked in, they check, do they want phone? Are they able to do telehealth? If they can, it's really strongly recommended. They send them a tip sheet with all the information. They help them do a trial run if they need to, all these sorts of things, just to make sure that they can be as confident as possible with the technology.
So anecdotally, what has been the response from your clients? What have you heard?
Yeah, it's been really mixed, surprisingly. Some people have really loved the convenience. Like I've got clients who work full time, and they want to do sessions like immediately after they've clocked off work or on their lunch break and that sort of thing. And they love it because otherwise they just can't get into a service. Our sort of DNA rate, so like our attendance rate it was pretty good before this, but it's gone up. Like people just don't miss appointments now. The other thing I would think is that some clients have said that they feel as though they don't get much of an emotional connection from the sessions. It's a bit harder to reflect. They can view it more as an information place. I have a couple of clients who have really complex trauma, and one of them mentioned she's flat out refused to do telehealth because she views it as a predatory medium because of her experiences. So you know, for some clients, it's not great. And then I've got a client with autism spectrum disorder, again, who finds video, well, I found one who's found it really great because they're so familiar with the video, and another who's found it really tough because it's just another layer of information that's removed that makes it difficult for them to participate in the conversation.
Yeah, I think you're reflecting what I'm hearing sort of more broadly, which is I don't think telehealth is going to be replacing face-to-face counselling sessions.
I hope not.
Long term. And that, yeah, there's quite a mixed response. And even some people, I think, who were really excited and engaged in the process initially have sort of come back and said, oh, I'm really looking forward to being able to come in face-to-face to the office. But then there are, as you say, there are other people who probably would never go anywhere near a counselling service, who would never set foot in an office, who we're able to reach using this medium and couldn't do that previously.
Yeah, I think it sets the bar lower for engagement, which is good and bad. It's good in that it gets people in who perhaps ordinarily wouldn't. It makes it easier for them to access it if they can't. And at the same time, it because the bar is a bit lower, you might have to do a bit more work at the front end, framing up, this is what counselling is, this is what we're actually here to do, and there's an expectation that you're going to do some work, not just me talking at you.
That's right. Well,
And if I could just come in, I mean, this is what the evidence tells us, particularly there's not as much evidence in the alcohol and drug arena, but certainly in the mental health area and other areas of health. And it tells us that for some people, it removes practical barriers. For some people, so being able to get to a session, the tyranny of distance, particularly in remote regions, the privacy and accessibility together that are happen. And the evidence tells us that for some people, it's as effective and it is a preferred method. And for other people, it's just not. And so, you know, some people say, well, where are we going to be post-COVID? Are we going to see governments just investing in this? Well, I hope they do invest in telehealth or continue to invest more, but it will be an adjunct. And certainly going outside the evidence where I've seen it done very well, it's done in combination with good investment in treatment services as well that people can access. And then you give people a choice. And then if they need to or want to see someone face to face, they can. If they want to do both, they can. And as a way of keeping in touch with people and just having brief catch-ups and follow-ups and for the want of a better term, booster or follow-up sessions and remaining connected, it can be a really useful adjunct to face-to-face treatment. But you can't have a sort of economic drive where you say, oh, this will save us money. We don't need buildings. We just need good computer equipment. We actually need to have investment in both areas. So I would hope post-COVID and we continue to see a stronger investment in telehealth, but it must not be at the expense of the need to actually further invest in our fields. The alcohol and drug field is woefully underfunded. It's much better than it was 10 years ago, but it's still got a way to go. But I think it's a way in which we can enhance access, we can have better outreach, and for some people, it will be a preferred medium, either because of practicalities or it just works for them.
yeah, well, Steve, you've preempted our final question, which we'll continue on with that discussion in a moment. But I'd just like to invite the participants. We're going to respond to questions from you in a moment. So if you could start typing your questions into the Q&A box. And in the meantime, while we're waiting to get your questions, we'll continue this discussion. If we all imagine that it's 2022, Trump and COVID and pajama pants are a distant memory. I've managed to have my hair done at least several times since then. And we're all able to go for holidays in both South Australia and WA. So what is the role of telehealth in the toolkit of health providers, let's say specifically in the AOD sector? And where does that fit in, and what sort of training do you think that people need to be getting in order to work from this perspective, and training and experience? So maybe we'll move on to you, Robert.
Well, I think that it's a fantastic adjunct, particularly for rural and remote people. In South Australia, we've got populations which suffer badly from geographic isolation and lack of access to resources. So rural and remote communities, we try very hard to provide accessible services, but it doesn't have the full gamut of what is available in the city. InReach through this is particularly useful. But having said that, in my experience, and it's changing, there's a lot of people that this is a high bar to get over. Once they've gotten over it, it's okay. But we found initially that we've had to get somebody to work with them to get the technology right and get them connected to it. I think the other thing that's going to really improve is bandwidth, because I can tell you that if I'm talking to somebody who's on high definition video, it is completely different experience to low definition. So I think as bandwidth improves, those nuances of picking up nonverbal cues and feeling more as if you're in the room will be there. And that we'll develop our etiquette of how we manage social interactions for counselling, that it is seen as a counselling session, not a conversation. I think, it's really important that we're clear. We're there to do work cooperatively. It's not a conversation that just ambles through a series of questions and answers that doesn't have a purpose.
James?
I think I completely agree about the idea of distance, because as I said, we're a fairly small and specialized service, and I think there's quite a few of those in the AOD sector. And I'm working, for instance, with someone out in Kilmore, and then someone on Phillip Island, and some people in Melton, and one of my colleagues has clients out in Ringwood and further out than that. We know that there's a lot of need as well, like out in Gippsland and that sort of area. So we really like the idea of telehealth, and we sort of try to arrange a first session face-to-face if at all possible. And I know it's tough for people to drive that distance, but if they can do it at least once, it seems to really help cement a good bond for future sessions. And so I think it's something that we're probably going to be doing a lot more of, and it's going to stick around. But it like everything, it's got to have that real clinical judgment. I don't think it's something where a bureaucrat or a funding body can simply decide on the basis of numbers.
Thank you. Steve, did you want to add anything?
Well, unfortunately, they do sometimes make those decisions based on numbers, but they shouldn't. So yeah, look, all of the above, and I think 2 years ago, I suspect we wouldn't have been able to have the telehealth response that we've had now. I mean, the platforms and the bandwidth that have changed relatively recently have made a dramatic change in this. I didn't think it was going to be possible to have the working from home, let alone have the connection with people in a counselling encounter that has happened. And as Robert says, then just think about what the leaps might be as we improve the technology and as we improve our capability of using it. And I think one of the things that has to happen is agencies need to develop guidelines and policies and procedures that are simple to understand, both for clinicians and, as we've heard in this discussion, for the consumers of our services. I think we've also got to recognise that remote isn't always in the far northwest of WA. Sometimes you can live in Perth and be remote. I mean, Victoria, well, Melbourne has a pretty good public transport system. Our public transport system is appalling. And it can take you 1.5 to 2 hours just to travel 10 kilometers because of the way the public transport system is. So if you've no money, if you're time poor, or if you just don't want to spend 4 hours traveling to and from a counselling session. So I think we need to think not just about how we make telehealth ensure our services are more accessible. We also need to be thinking about how we make our services more accessible. Robert knows I've used this example a few times, but I was really impressed. An Aboriginal woman, Auntie Izzy in South Australia, she was on the board of chair of the board of an Aboriginal service in country South Australia, and she had very low turnout rates. They'd have maybe 30% attendances. They bought a minibus and they picked people up, and suddenly they had an 80–90% attendance rate. So I think that means that we should be thinking not just about telehealth, but different ways in which we can make our services more accessible to people, both in the hours that we operate, whether we have centralized or remote offices, and whether we buy transport to get people in. And we should be thinking about access in terms of telehealth in that way. But I think we should also be saying to government, we continue to say there's a shortfall in funding for the number of people who are affected by drugs. Governments have got an interest in the drug and alcohol area that they didn't have before. It has actually been front of mind for very senior politicians in state and in federal government. So I think there's an opportunity for us to press for much more investment in our face-to-face counselling services. As James said, that's critically important, but coincidentally saying we can also make this better by giving some people the choice and having an adjunct to our services. But at the end of the day, for a lot of people, our telehealth services will be a front door into our face-to-face services. And we can't just paint up the front door. We need to make sure that there's other things behind it.
Thank you. And just to add from an education point of view, up until fairly recently, providing telehealth services weren't even considered to be legitimate services as far as placement and training opportunities were involved. So if someone did a placement at somewhere like Lifeline or in other telehealth service industries, they weren't allowed to count that towards registration as a psychologist or other health professional. So I'm very much looking forward to the time that changes and that we recognise that not only are these things counted as providing counselling and essential services, but that they should be mandatory parts of training programs, that we teach students how to deliver services virtually and using other modalities rather than face-to-face.
So they should do your course.
Absolutely. We'll talk about that in a moment. Oh, but of course, providing telehealth, telehealth training in how to deliver telehealth consultations, I think should be part of every course for people who work in the helping professions. And I think undoubtedly it will be from now on. So just having a look at some of the questions that people have written, and we'll respond to those. So a question for James. James, are you able to share the client contract that Reconnexion has developed for telehealth counselling?
I can probably dig it up. I'm not sure what would be the easiest way for that to happen technologically and that sort of thing.
Yeah, maybe if you are able to share that, maybe you could send it to Varda and the person who's asked that question might be able to request that
Easy.
through VADA. Another question. Are there recommended guidelines on telehealth privacy and confidentiality or sample consent forms relevant to telehealth? So is there sort of, a one-stop shop to go to get all this information, or where do we go to find out?
I'm not aware of a one-stop shop. I am aware of some agencies that have developed. They're not that different, and why should they be from any other confidentiality processes and policies and agreements? The principles are exactly the same. There just might be some things that you might emphasize in your client encounter as opposed to a policy guideline. So that might be an invitation for agencies to reflect on and visit their confidentiality guidelines. That and then there are, most of the peaks can help direct people to sample and quality examples. Quality assurance processes that many of the agencies are, if not most of the agencies are engaged in, do include this. It might be a case of visiting them to see whether anything in their telehealth processes requires amendment or emphasis.
Would anyone else like to add anything there? James?
I think Steve's right that it follows a generic approach. I know that the Alcohol and Drug Information Services have had to deal with this issue because of the complexity of managing online calls. When we transferred over to telemedicine, we just modified our consent form to include the fact that it would enable us to use that medium. But I'm not aware of a place you could go to as a one-stop shop for that information. But of course, you can have a look at our guidelines, which gives detailed guidance on the how to do and what to do, and that's available online.
Yeah, I'd just like to add to that as has been mentioned, we are starting a graduate certificate of telehealth through Monash University, and one of the reasons we're doing that is for an opportunity for people who want to work either primarily or significantly from a telehealth perspective. The purpose of the course will be to enable people to set up a idiosyncratic type of practice that's going to be suitable for them. So just like any other type of practice that in allied health or elsewhere, there are going to be things that are going to be specific to your particular client group and to the particular type of service that you want to provide. So our course is going to give people a breadth of different types of legal and ethical and other requirements that are available in this area to enable people to sort out what's going to be the correct approach to take for their particular service. Having said that, what I've discovered in setting this course up is that there are a lot of really excellent texts available in this area. The majority of them, unfortunately, are either European or American, which means that they don't necessarily fit into Australian frameworks, but there are Australian texts and guidelines and articles available. So after this webinar, for people who are interested in getting more information, they can send an email to VADA, and VADA will forward it to either myself or to the panelists, the relevant panelists, who could then perhaps provide people with access to these reference materials and other access to other materials that are available.
And we've already touched on, there are a variety of agencies like Lifeline who've got years of experience. There's alcohol and drug telephone services in Victoria, South Australia, Western Australia, and so on, that have been running for several decades. So that's the other, is to talk to them about the resources they have, and if they're willing to talk to them about the experiences they've had, and where they've maybe felt the need to make amendments or emphases, so that it is not just Australian, but also maybe relevant to your particular regional challenges.
Good. And now another question we've had, which is very dear to my heart because it's my particular area of interest, is around providing group sessions via audio or video conferencing. So have any of our panelists had particular experience in providing group sessions, and do you have any tips to the audience about how you do that effectively?
I see James is unmuted, so he's ready to go.
I was actually going to leave that one to Steve or Robert. We're in the process of setting up an online support group, but it hasn't quite come together yet. But the main things just that we're thinking about are, you know, looking at so many faces on screen at once, and when you're trying to do process things, we're trying to keep the group sizes quite small for that reason. And I think 2 facilitators at a minimum, because you really do need someone to be able to attend to things that can go wrong in any kind of group setting.
So we've had experience mainly with couples, not with groups. Having said that, and leading on from what James said, one of the key things in groups is to keep it small. Ideally, the number of faces should be no more than 9, because it enables you to actually connect to everybody and to look at what they're doing. We've also established the kind of the Zoom rules that we're all familiar with now about being on mute unless you're talking. We encourage everybody to have the video going. I've tried this. We're a WHO collaborating centre, so we're doing a lot of work in Asia. And as Steve mentioned, we've been doing some work in the Philippines. Their bandwidth is appalling. And so when everybody's got video on, it becomes very jolty and jerky. So, but domestically here, it's kind of worked okay. I think we're basically trying to apply the Zoom rules and to limit numbers and for people to be respectful of each other's space. So we've been limited trials on that, limited success, but it seems to be something that is an option, but wouldn't be my go-to option.
Yes, I mean, same thing. There's limited guidance on this, but the principles of any group work would be the sort of principles that you'd start with, and then you'd marry that to the practicalities. And I think even for me, 9, trying to run an education session with 9 faces is sometimes a challenge. I'd be thinking probably about investing quite a bit of time in, Robert was touching on the sort of, if you like, the online and group etiquette, which you would normally have to do in group work or online. So it's about, but I think it is a little bit harder to do that. So spending a bit of time doing that. I'd be thinking about matching as well, so that you're not just creating a group at random, but you're trying to create, you've got to think very carefully about the potential dynamic within the group, which might be age, gender, for the want of a better term, personality influenced. And I think James's point, you definitely need, if you can, 2 people. Because it's harder. You don't have the ease and the non-verbals to just slow things down and say, just a minute, James, let Robert talk, which is much easier to do when you're in a room. So I think, again, it's the same principles you would use in any group work, but you've got to emphasize certain things, and I think emphasizing the matching. But there's not much of a rule book on this. This is relatively new phenomena. So I think it is about going cautiously, going with support, having small numbers, thinking carefully about matching, ensuring that the group / online etiquette is really thought through and communicated well.
Thanks, Stephen. Yes, you're quite right. There isn't a lot of guidelines around this, and a lot of it is trial and error. And we've been running sessions, our breakthrough sessions for family members online during this COVID experience. And we are getting people from Burma and from the UK who are joining our groups, which is wonderful in some respects. But you also find that there are people who must be scouring the internet to find groups all over the world that they can join, just so that they can push their own agendas or you know, take over the group, if for want of a better term. And so, you know, managing those people and being able to exclude them from your group and manage who attends and who doesn't and all those sorts of things are things that I think we are just learning in this space. So unfortunately, we're running out of time, which is really sad for me. I told you that I could talk about this all day, and I'm sure many of us could, but we need to go off and have some lunch or breakfast, maybe, Steve, in WA. So thank you so much to my wonderful panelists. Certainly an incredible breadth and depth of experience in this area. We haven't been able to answer all the questions. So for those of you who haven't had their questions answered, if you do send an email to Julia at VADA, she will make sure that those questions are passed on to the relevant person who might be able to answer them. I'd also like to encourage people who are interested in learning more about this space to consider enrolling in a graduate certificate of Telehealth, which is an online course, so we can do that from anywhere across the world. And it's going to be a really exciting course that's just commencing in 2021. And I think, you know, it will be really sort of channeling this new environment that we find ourselves in because of COVID-19, but as we know, has been around for quite a long time. And I'd also like to invite you all to attend the next VADA Service Providers Conference webinar, which looks really exciting to me. It's on the 27th of October at 10:30 to 12:30. The topic is harm reduction, innovation and challenges, what we can learn from other jurisdictions. And the speakers for this webinar include Jane Buxton, Professor and Director at the University of British Columbia in Vancouver, and also Dan Lugman from Turning Point will be talking, and he'll be talking about the new SBS series that many of you might have seen advertised called Addicted Australia, which commences on the 10th of November. So I also am really looking forward to that, and I think that should be an interesting addition to the discussion across Australia around the whole topic of addiction. So thank you again to VADA for putting this webinar together, and to the presenters, and thank you everyone who's stuck around to the end, and enjoy the rest of your day. Bye.
Go to the Assist portal, and thank you, Naomi, for your fantastic facilitation.
Thank you, Steve. Thank you, everybody. Bye-bye.